everyone. Just to introduce myself, my name is Matt Camarda. I am the Advocacy and Public Policy Director for the National Alliance on Mental Illness of New Jersey, NAMI, New Jersey. And I thank you all for coming to this presentation that I have this evening about what you need to know about mental health parity. Just to say a few things before we start. I will leave time at the end. There will be time at the end for any questions that people might have. It's a lot of information. It may feel a little overwhelming. It certainly felt a little overwhelming to me as I was working on this presentation and did the research for it. So if you get, confused or have any questions about terms or what things mean, I'm happy to take any questions. You can put them in the chat, but I won't, address them until the presentation is over. So to start, and thank you all. It looks like everybody is muted, which is great. So to start, I'm just going to give a brief overview of what I'm going to be talking about today. Just giving like a roadmap so you guys know what I'm going to talk about. So first, I'm going to describe, like in really basic terms, what mental health parity is. I'll define a few terms associated with mental health parity and insurance that will pop up throughout the presentation, and then just talk briefly about why mental health parity is important to us. I'm going to give a little history. I mean, it's a little more than a little on federal mental health parity laws, just some important historical trends and how certain laws came to be and what's in them and like what that means for like parity in practice. I'll talk a little bit about what types of plans are covered under mental health parity and what plans are not. I'll talk about some of the challenges associated with enforcing parity because there are several. And then I'll talk about how all of us, can be part of the solution to strengthening parity. And I'll just conclude with a, recap, and then I'll give all of you the chance to ask me questions. So to start, the definition of parity, the Merriam-Webster definition of parity, is the quality or state of being equal or equivalent. And how that fits into mental health parity is that it requires that insurance benefits for mental health and substance use conditions, so covering treatment for those conditions, must be equal to coverage for other types of health care. And then a couple of terms that I think that will pop up, throughout the presentation because they pertain to parity are quantitative and non-quantitative treatment limitations. Quantitative are they're numerical in nature and are things such as copays, coinsurance, deductibles, limits on things like the number of days spent in a hospital or the number of visits to a provider. These things are pretty easy to measure. Non-quantitative treatment limitations are non-numerical limits on the scope or duration of treatment and include a whole host of different processes and policies, procedures such as standards for providers to be admitted into the network. They include things like the drug formularies for the plan, so like what drugs are actually going to be covered, restrictions on geography, on provider specialty, on step therapy, which is a form of prior authorization where the insurance company kind of decides, okay, you're going to try these drugs first, and if they don't work, then you can try something else. It's very often the case that parity violations are non-quantitative because the quantitative are written into the plan and the non-quantitative are a little more kind of behind the curtain and a little bit less transparent and easier for insurance companies to apply stricter standards for. And so why all of this is important is because historically mental health and substance use care have not been covered equally by insurance. And because of that, millions of our, individuals and families have had to face financial hardship or go without necessary care. And despite landmark legislation to establish parity requirements, too many still face additional barriers to care. And we'll get into partly why this is, but parity enforcement is fragmented between different federal and state agencies, which creates confusion. So to start out with my history of federal mental health parity, I would kind of start with around the World War II slash post World War II era. One of the important developments for American healthcare is the establishment of employer-sponsored health insurance. This is a phenomenon that we see as pretty much defining our health insurance system today. Many of us, if if you have a job, it's very likely your insurance comes from your job. It's sort of assumed in our country that you will receive health insurance through your job unless you're old or unless you have low income or disabled in some way. And so as this system comes to develop, you see in the 50s the coverage of some psychiatric hospital care. You also see the president at that time, 1961, Kennedy, directing the U.S. Civil Service Commission to require the Federal Employee Health Benefits Program to cover psychiatric illness at an equivalent level to general care. You'll see during this time that while the number of employers offering some kind of mental health benefits did increase, so did limitations on the kinds of care and the amount of care that somebody could receive. So you would see it's sort of an increase in the amount of, plans that may be offering this some amount of care, but those limitations increase. And this obviously created issues which the state legislatures tried to sort of address, establishing some minimum benefits laws, but not really going as far as to say they should be at parity. One of the things that made this challenging and weakened states' efforts to do so is the Employee Retirement and Income Security Act, or ERISA, which prevented states from regulating self-funded employer insurance, which is right now the overwhelming majority of employers sponsored health insurance is self-funded, which essentially means they are taking on the full risk and responsibility of that insurance. And so it basically prevented state laws from really having a bigger impact on parity. And as employers were moving toward sort of covering less and less, that was the same for the federal employee program too. And they were allowed to gradually impose limits on mental health care. And by 1981, the only plan in the employee benefits program for federal employees that provided parity was allowed to scale back. So what you see is a diminishment of mental health coverage because there was this sense that it was going to cost more. So to get into sort of more of a federal level, because there was no parity legislation and because there was a need for it, it created pressure on Congress to take some action to address that issue. And so in 1992, the first mental health parity bill was proposed by two Republican senators, John Danforth and Pete Dominici. But this didn't really go anywhere, and partly because it was considered very expensive. Um, President Bill Clinton in the early 1990s attempted to make major changes to the healthcare system, but ultimately that failed. And one of the things that he, included as part of that larger proposal was some, requirement for mental health coverage with the extension of full parity eventually. But because that failed, it also led to the failure of parity. But we did have senators take up the mantle again in later years trying to pass a bill. They tried to attach one to the HIPAA legislation that you're probably all familiar with. But that again failed because it was considered too expensive. One of the conflicts at that time was that the concept of managed care, which may be familiar to some of you and not familiar to others, but basically it's the idea of the insurance companies really playing a much larger role in sort of taking over the care, whether that be through utilization management, things like prior authorization, provider networks, really kind of imposing limits that were intended to cost save. And because of managed care, um, there were assumptions that were made by some advocates that that parity would cost less. But those assumptions were not necessarily used by Congressional Budget Office or other advocates. So there was a conflict. Ultimately, a very scaled down version of parity was passed that established parity for annual and lifetime limits only for large employers and did not include any sort of substance use. And unfortunately, this proved to be ineffective, and insurance plans were able to circumvent it by limiting hospital stays and out-of-patient visits. So because of sort of the lack of effectiveness of this law, it was more seen as a symbolic measure, but it did raise awareness of the issue, and it didn't necessarily just fall by the wayside. States continued to pass laws, and President Clinton actually ordered the Office of Personnel Management to implement mental health substance use parity for the federal employee plan. And this was an important development because it allowed sort of proof of concept for parity and allowed researchers to really study, okay, what is this going to look like? What is the actual impact of parity on cost? And what they found was that it actually didn't have very much impact on cost. They found that it didn't have much impact on cost, but it also reduced out of pocket spending for beneficiaries. This was a helpful development because employers and insurance companies could see that it wasn't going to break the bank. And they could also see that mental health care was actually really positive for their employees. And another positive development was that there were members of Congress who were more willing to come forward with stories of their own lived experience with mental health and substance use issues. Members like Patrick Kennedy and Jim Ramstad had very personal experiences and were able to talk with their own colleagues about that. And so over the years, that helped move the issue. And so negotiations did take several years, but they involved business groups and insurance groups. They involved patient advocacy groups like NAMI, Mental Health America, other groups that also represented providers. And ultimately, a compromise emerged that is now referred to as the Mental Health Parity and Addiction Equity Act of 2008. And it was helped, the passage of the bill was helped by the fact that we were in the midst of the financial crisis, and it was attached to the Troubled Asset Relief Program, or TARP, that helped both bills get across the finish line. So just want to talk briefly about the provisions of federal parity law because it really serves as the foundation of what we've come to expect from federal parity. First off, what it doesn't do, it does not require coverage of mental health and substance use treatment. It only requires that when those things are covered, that parity is required. It covers large employer plans like the previous bill, but it also covers Medicaid managed care, Children's Health Insurance Program, or CHIP, states and localities, but they had an option to opt out. It also allowed a plan to file for a 1-year exemption if the insurance plan could prove that costs rose by 1% that were attributable to parity. What this means in practice, financial requirements and treatment limitations must be equal to those for medical and surgical care. That means in-network and out-of-network parity for inpatient and outpatient care. It means parity for emergency benefits, and it means parity for prescription drug benefits. And like the previous bill, it means no annual and lifetime dollar limits, but it also means that addiction is covered under these categories. It also, as part of the compromise, insurance plans could define the specific conditions that were covered under parity, and states are allowed to impose more stringent parity laws than the federal government. And the way that parity is supposed to be monitored through that bill is that a government accountability office study is to be proposed or produced, and every 2 years, labor secretary submits a report documenting how parity is being enforced. So while the Affordable Care Act wasn't specifically a parity law, I bring it up just because there are a couple of important provisions related to coverage and related to parity. So the first people might be familiar with, it prohibited denial of coverage or charging more for a pre-existing condition. This matters if you say are somebody with depression, schizophrenia, bipolar disorder. You cannot be turned away or rejected by insurance because of those conditions. It expanded Medicaid to 138% of the federal poverty line. Now, this was a requirement, but the Supreme Court ultimately threw that requirement out, and 40 states have since opted in, including New Jersey. 10 have not. It also set up an individual exchange. Each state could use their own or the federal government's. So if you were not, say, employed, or you didn't, have insurance through your job, you could purchase a plan through one of those exchanges. And tax credits would subsidize your insurance up to 400% of the poverty line. It required individual market and small group plans, so more like the smaller employers that weren't covered under the previous law, to cover 10 essential health benefits, including mental health and substance use, and expanded parity protections to those plans, and also for those who were expanded in Medicaid and CHIP. There have been, since those two laws that I mentioned, a couple of other developments that are just important to note that have been included in other pieces of legislation. The 21st Century Cures Act, which may or may not have heard of, had some additional requirements that agencies disseminate guidance on parity law. It also clarifies that eating disorders, and specifically residential treatment for eating disorders, are considered under parity law, which is important because eating disorders are often overlooked as a mental health issue. Consolidated Appropriations Act of 2021 required plans to document that non-quantitative, which is the ones we were talking about earlier, on behavioral health benefits meet parity standards through comparative analysis. Then they have to submit those comparative analyses to federal or state authorities when requested, and also request if people like us, regular consumers or family members on those plans, ask for those analyses, that they also send them to us too. And another important development, I mentioned that state and local governments were exempt or allowed to exempt themselves from parity. This law, the Consolidated Appropriations Act of 23, eliminated that option for large employers of non-federal governments. So I'll mention this earlier, but New Jersey had previously opted out, but had opted back in about 10 years ago. And then President Biden has proposed a couple of rules to strengthen parity. They have to kind of take more effort to study and make sure that their networks and their payments to providers are adequate, and make sure that they're improving access where it's needed, and also apply a more strict standard to non-quantitative treatment limitations to make sure, again, that they are not being applied more strictly to mental health and substance use than regular other health care. So the next two slides are basically just types of plans and whether or not they fall under parity. So hope that this will be of some help to people who maybe aren't sure whether their plans fall under parity. So large employer, small employer, and federal employee health benefits all fall under parity. As I had said before, the non-federal government, large employers do now fall under parity. New Jersey actually ended its policy of denying parity to public workers in 2013. This was a big victory for the state, and it was due in part to NAMI New Jersey's advocacy and my predecessor, Phil Lubitz. Um, Faith-based organizations and retiree organizations are not covered under parity. Medicare and Medicare Advantage is not covered under parity. And TRICARE, which is the program for military and their families, are not covered under parity. Children's health insurance program is covered under parity. Medicaid is generally covered under parity as long as you are under a managed care plan. It doesn't have to, it doesn't require that your mental health services be on a managed care basis. As long as you are on a managed care plan, you are covered under parity. And for New Jersey, that means that, we are, our, Medicaid population is being served by what's called MCOs or managed care organizations, and so they are covered under parity. And then individual health plans, if you have a plan off of the marketplace, you are also covered under parity. So now I just want to talk briefly about the challenges of enforcing parity. As I sort of described earlier, there have been numerous attempts by the federal government in legislation and in agency actions to force transparency and greater compliance with parity. There are comprehensive protections for many in the law, but unfortunately, robust enforcement is elusive. One reason is that it took a really long time to write the rules. As you can see, 2013 for private insurers and 2016 for Medicaid and CHIP. That's 5 and 8 years. That's a long time. And unfortunately, the law, it had monitoring tools, but didn't necessarily have really strong punishment mechanisms. There aren't like a whole lot of ways to sort of go after the insurance plans that aren't following parity. And without rigorous enforcement, insurers have lacked incentives to make sure that their plans comply and take advantage of gray areas. And another issue that I'll talk about a little bit later is that there are many agencies, federal and state agencies, that are tasked with enforcing parity. And it's not obvious. You have to kind of know who is the agency that is enforcing parity under your plan. I'll go over that in a few slides, but it's just definitely a challenge. And then just to note, over the last several years, there have been many reports, both governmental and non-governmental, that have called attention to the various ways that plans are not necessarily complying with parity. So now I want to talk about how all of us can be a part of the solution to strengthening parity. And the first thing I want to talk about is spotting parity violation. I talked earlier about quantitative and non-quantitative treatment limitations. Now I'm just going to talk about them in the context of how this might be a parity violation. In your own life, in your insurance plan, if you're noticing fewer visits are allowed or covered for behavioral health care than they are for medical or surgical care, that may be a parity violation. If your plan doesn't cover residential or intensive treatment, but does for other conditions, or you're paying higher costs for mental health and substance use disorder treatment than medical or surgical care, that could include things like co-pays, co-insurance, deductibles. Those may all be signs that the plan that you have is violating parity. For non-quantitative treatment limitations, it could be that your care is being denied as not medically necessary, but you aren't necessarily finding that for medical or surgical care. You may also find that you're constantly having to get prior authorization, that your medications that you would normally be taking are subject to really strict step therapy requirements, and it's making it really hard for you to get access to the meds that actually work for you. It may be that your treatment is subject to really frequent reviews, that providers are constantly being hit up for information and wondering, oh, is it going to be covered tomorrow? Is it going to be covered the next day? Those may all be signs that your plan is violating parity. Another really common example is really narrow networks. Many people struggle with being able to find a provider that is in their network, but may not struggle to find such a provider for another condition that's not behavioral health. We refer to this as like ghost networks. So now that you may have spotted a parity violation, the next step is reporting it. It's important to note that you have the right to complain, and having any sort of retaliation by insurance companies is completely against the law. And it's really important that you complain if you have an issue, because enforcement is often based on whether people file complaints at all. So if no one files a complaint, there may be a presumption that, oh, everything is fine. The plans are, doing what they're supposed to, and it may just be that people don't know, you know, that they have the option to complain. So starting by contacting the New Jersey Department of Banking and Insurance. This may not be the actual agency that oversees the plan, but it's important that they know, even if the complaint needs to go somewhere else. You also want to discuss the care denial with your provider, and you can make a plan with them as to how you're going to address it with your insurance plan. You can contact the plan's customer service office directly, and sometimes that in and of itself can resolve the issue. And if you're still denied, you can submit a written appeal to the insurance plan. And again, if you're still denied, you can submit a written appeal to the agency in charge of that plan. So just to be helpful in terms of understanding like which agency oversees which insurance plan, I just have, a couple of them here. This is not all inclusive, but just the ones in black are important to note because they are ones in which the state of New Jersey has some oversight and control over. So individual health plans, the federal or state exchange, our insurance agency has some oversight, as well as the Centers for Medicare and Medicaid. Non-exchange plans, small group or individual, same deal is the banking and insurance, our state insurance agency, and then Medicaid and CHIP is shared between our Division of Medical Assistance and Health Services and CMS. Employer-based plans, which many of you may have, is actually regulated by the Department of Labor. We're actually working with the Department of Labor to have a separate presentation later in the year where they talk about the process by which you would go about, filing a parity complaint with specifically the Department of Labor. And we had one last year as well. And then if you are an employee of the federal government, obviously excluding military, you would be under the Office of Personnel Management. So now that we talked about how an individual can address a parity violation in their own plan, we can talk a little bit about how we together can advocate for stronger parity. One of the things that sort of when I was researching this issue that I learned about was that New Jersey, and again, in large part due to NAMI New Jersey advocacy, did pass its own state parity law that required actions by both the insurance plans and the Department of Banking and Insurance, that they would have to submit reports every year, basically documenting that they're following the law. And what I've discovered in talking to many people is that this is not being enforced. This law was passed a little bit before COVID, less than a year before COVID, and it seems as though it's kind of, fallen by the wayside. One thing that we as advocates ought to do is ask the Department of Banking and Insurance and the insurance plans to enforce both federal and state parity law. They have obligations to transparency. They have obligations to tell the public what they are doing to enforce parity law. We should also ask our lawmakers to pass additional parity legislation. Some of the ideas that have been proposed by other states involve strengthening network adequacy standards, so making sure that our networks have the providers that we need. We're also making sure that insurers are basing any determination of medical necessity on criteria that is generally accepted by the profession in which they're judging. So essentially using nonprofit professional review criteria rather than the standards that they use, which are often proprietary, not transparent, not available to the public, and often used to deny care to people that need it. Additionally, there is a bill that we are supporting, S 1192, that would require insurance coverage for prescription drugs for people with serious mental illness without utilization management and things like prior authorization and step therapy. This is a little bit different from parity because it's trying to exempt a population from a set of processes instead of saying that they be considered the same. So it's kind of going one step further than that, but it's still important because we know there are barriers to treatment for those individuals. We're also encouraging people to share stories with us at listening sessions on May 29th, 1 to 2:30 p.m. and May 30th, 6 to 7:30 p.m. Um, I'm hoping that people will sign up for these sessions and that we can have a good number of people. But if people can't come, I welcome anyone who has a story to send it to me at mcamarda@namiandj.org. We also have a survey that I have been sort of circulating over the last month and a half. And I do ask about insurance barriers in the survey. We've gotten a lot of responses, so thank you to anyone who has responded. And then I have this slide here because um, even though New Jersey has not really taken any major enforcement actions on insurance plans, it's really important to note that other states have. Since 2017, 10 states have levied over $31 million in fines on over 30 insurance plans. So I just, this is just a smattering, an example here, but I just want to highlight this because it is possible. It is something that we can do if we chose to do it, and should be some sort of like a guiding light for advocates who do support parity, to say, hey, this is something that has been done. And many of these states are like neighbors, Delaware, New York, you know, these are not states that are all that different, wildly different from New Jersey. So just to conclude, mental health parity means insurance benefits for mental health and substance use care must be equal to coverage for other types of health care. The federal parity law that I talked about earlier, MHPAEA for short, established that insurance must cover mental health and substance use equal to other types of care if it is covered by the insurance plan. The Affordable Care Act strengthened certain protections. It strengthened coverage by creating individual exchanges, by requiring that people with pre-existing conditions be covered regardless, by expanding Medicaid, by creating essential health benefits for certain plans, and for extension of parity to individual and small group plans. Parity is difficult to enforce, in part due to the rulemaking process being long, and oversight being spread across many agencies. However, progress is still being made, and you can help by spotting and reporting parity violations, advocating for legislative change and agency enforcement, and also sharing your stories with us on, May 29th or May 30th at our listening sessions, or emailing me directly at mcamarda@namiNJ.org. So I want to thank everyone for joining us today for this presentation. And I would like to now cede the floor to if anyone has any questions for me. I just want to note, if you don't think of the question, but you think of it tomorrow, you are still more than welcome to share your question with me, and I'll try to get back to you. And if I can't answer it right now, I will do my best to, come up with an answer and get back to you as soon as possible.